Hi, and welcome to the APAPP podcast. I'm Corinne Young. I am a nurse practitioner and the host of today's podcast. And today I am talking to Brian Bizik. He is a physician assistant with over 20 years of clinical experience. Currently, Brian is the respiratory and allergy care coordinator for the Terry Riley Health Centers in Boise, Idaho. Brian is the past president of the Association of Physician Assistants in Allergy, Asthma, and Immunology, and past member of the Idaho State Asthma Collaborative. Brian enjoys spending time with his family and trying to survive Spartan races, and is also an avid birder, which for the rest of us know that as a bird watcher. He's trying to avoid getting HP, so he doesn't allow them in his house. He just looks at them from afar.
Wild birds, we love those. Yeah, the ones, hawks and owls and that.
Oh my goodness. Something about you, asthma, allergy, immunology, folks. Amanda Michaud also, who you probably have seen on some other podcasts. She has falcons, right? She has some birds of prey that she trains, and so you guys are really into that. Pulmonary, we're like scared to death pounding birds
hockey
around.
Player, yeah, and Florida, because Florida is a hockey hotspot. It kind of is now, but yeah, we have those quirky things about us, but that's why we love allergy.
Yeah, I guess so. Keep it every business. Well, today we are going to be talking about asthma-COPD overlap, which is kind of a hot topic. I think that, years ago, it was kind of a very gray area. We were trying to figure out, is it its own distinct disease state? Is it two separate states? Do they coexist? Are they competing with each other? What exactly is it? So let's start with definitions that are out there currently on what asthma-COPD overlap is.
Yeah, I mean, it is a hot topic in some ways because the definitions have been changing and there's been some back and forth. And in the asthma-COPD overlap syndrome, that last part is really the controversy because there's good acceptance of the idea that, hey, this is a thing. Asthma and COPD can exist by themselves. And the definition that Gold has put forward and Gene has agreed on, they did one in 2017 and Gold kind of updated it this last year, is to say asthma and COPD are separate entities, but they certainly can exist at the same time in one patient. And so let's go ahead and acknowledge these two entities. Let's acknowledge that they exist, that people can, we'll get to in a second, but they can kind of morph from one to the other, that they exist, but this isn't an entity in of itself. It's not a syndrome in and of itself where there's a unique kind of thing. Once they get into this, this Venn diagram merges, once they're there, all these kind of new things happen. That's really not the case. It's that they have one chronic disease, asthma or COPD, and then for whatever reason, they now have the other one. Maybe they smoke for a long time, whatever. So two disease states can overlap in one patient, not its own entity, but absolutely, I would even say it's more important now than it was even a few years ago, even if our definition has kind of pulled out the S part, that syndrome part, and are leaving that behind.
Yeah. And, sometimes people get a little confused about diagnosing it. I'll have students or newer APPs that are with me that'll say, hey, this patient with known COPD, they've got emphysema on their CAT scan, they've smoked for 50 years, and they don't have any remote history of asthma in their past, has a bronchodilator response of 12% and 200 milliliters. They must also have asthma, right? So that is not necessarily the case, correct?
Yeah, that's the case. Yeah, they may still have that. And there is a diagnosis code, so you can tell them it's J44.94, I think is what it was. But so there is a code. There is a code for this. But yeah, if you're looking at a patient and maybe they have a diagnosis of COPD, but they do spirometry or PFTs, and hey, they reversed. They had a very robust bronchodilator response. Okay, so they also have some of that reversal. And I'm just curious, are students often throwing out the asthma COPD overlap diagnosis still? I mean, is that still coming up?
Yeah, I think I do see it, especially with newer APPs. They feel that, well, if there's a bronchodilator response, not completely reversible, right? Because if it's reversible, it's not COPD. But let's say they have a significant response, they start thinking, well, it must be asthma. But we know that COPD patients can have hyperresponsiveness, which is important to know because of treatment plans, and they tend to have a higher morbidity and mortality rate, right? They tend to be more symptomatic and problematic. But they often just think if there's any type of reverse or a responsiveness to bronchodilator, it must be also asthma.
Yeah, and the going back to the definition idea, Gold says there are two entities, they can exist in one patient, and then they make the very bold statement, which is I praise them for saying, if your patient in front of you, they have COPD. So that patient, we've diagnosed them, we've met criteria, their FEV1 over FVC is less than zero point 0.7. So they met the criteria. They have COPD. Maybe they have emphysema or not. But they also have the criteria for asthma, and we're checking that box. So Gold says treat them like they're an asthmatic. And that's, so that's a big thing for a COPD organization to say, go ahead and treat them as an asthmatic. But really what that means for that patient is two things. There's two words here: steroids and biologics. Steroids meaning inhaled corticosteroids, because if that patient in front of you has COPD and they fall into any category but the last category on the Gold diagram, then inhaled corticosteroids are generally not recommended. So there are patients that may be on a LAMA-LABA or whatever. You're going to move them ahead to inhaled corticosteroids later in their therapy based on their exacerbation history, how many times they've been in the hospital or an inpatient. So that's how we're going to put them, and we're going to add those inhaled corticosteroids later. If, however, they also have asthma and they meet the criteria, they reverse. Maybe they have a history of asthma. I was looking at the old definitions. It was really interesting to look, and there was the first real kind of accepted one was 2007, and then one in 2011 said that the criteria had to have sputum eosinophilia to meet criteria. We wouldn't do that most of the time today. We would do serum, but so they've got COPD. We checked that box, but now they have asthma and they meet those criteria. Maybe they have elevated eosinophils and an allergic phenotype. At that point, then inhaled corticosteroids are no longer in the back, they're in the front. And we're going to move them up. And for most of those patients, it makes sense to say you have an asthma component and COPD. So inhaled corticosteroid makes sense. Their first line therapy, their efficacy is unquestioned in asthma, and they're probably the right thing for you too. And in all likelihood, a triple inhaler would make sense for a lot of those patients because they meet all the criteria. And then the second thing that you would consider is biologics. Now, if they just have COPD, as of today, as of our recording, there's not a biologic available for patients with that diagnosis. If that's the only diagnosis, it's COPD, either emphysema or chronic bronchitis. We don't have anything quite available yet, but maybe by the end of the year we will. But if they have asthma, then at least that's part of the thought process. Maybe this makes sense for them if they have if they meet criteria for other reasons, then I might consider biologics. So open up the Pandora's box, if you will, of treatment options. If they have COPD and they meet criteria for asthma, there's really nothing off the table. And a little steroid early in your therapy and consider, hey, I'm going to start them on inhaled corticosteroid, probably with the LAMA-LABA, although that's kind of up to you based on their history. But just be thinking about those early, and then in the right patient and something, if you do, think about biologic therapy. It may not be right for a lot, but some might fit that criteria.
I want to touch on something you said about the 2007, 2011 definition when we were still calling it a syndrome, asthma COPD overlap syndrome. And they talked about sputum eosinophils. Back then, we definitely thought of asthma as an eosinophilic type of lung disease and COPD as a neutrophilic lung disease. And we really felt like the two do not meet. And now we are understanding that there is an eosinophilic type of or type 2 COPD patient, just like there's a type 2 asthma patient. I think that's kind of where the syndrome became unstructured and they started saying, no, in fact, these are actually two totally different diseases, multiple phenotypes within each disease, but they can overlap in that you could have a neutrophilic COPD patient with an asthmatic type 2 history, or whatever. Those things can overlap. But also, like you said, meeting the criteria for asthma, when you look at the definitions of asthma, there's that history of these symptoms and triggers and that type of thing. And generally, you interrogate some of these patients and they'll start telling you, oh, yeah, I had trouble playing sports as a kid, or I was always having bronchitis. I was always sick. I had an inhaler, at some point in my adult life when I was younger. It's not generally a syndrome we're going to be seeing that they develop at 75.
Yeah,
Right.
right. It's not. And you're right. And the history is often there, even if it wasn't a formal diagnosis. But, for sure, those patients that have COPD, neutrophils may be driving a lot of it, but somewhere between a quarter and a third also have quite a bit of problematic eosinophilic inflammation. So it's not only that it's there, but, and you mentioned this right when we were coming into this, that those patients are more likely to get sick. So it's not just kind of an oddity. Hey, they have eosinophilic inflammation and maybe steroids are going to be more effective. That's true. But they also are at higher risk for almost everything: exacerbation, hospitalization, poor outcomes. And when they do have an exacerbation, they tend to do poorer than those without it. So yes, it's an interesting thing and it's an important thing. And you do want to get that out, and interrogate is the right word, because you have to really deep dive with them and have the time. But once you get that, you realize this is not only something I should think about treating. However, I want to do that differently, but this is something I really need to talk to them about. That eosinophilic inflammation, you have COPD and you have neutrophilic, but this other component that you have is actually not more important, but it's certainly relevant, can affect your outcomes, and it's going to affect what we do treatment wise. So yeah, very important. And that's why I thought this is in some ways getting more important of a topic, that not addressing that in a COPD patient, not looking at that eosinophilic part, if it's appropriate, is really not okay. It's on us to do that and to acknowledge that. And somebody asked me, a person that works in the industry last week, he said, "Do you do eosinophils on your COPD patients?" And I'm like, yeah, everyone. I can't not do it. I mean, if I don't have it, that's fine. But I really don't like to proceed past very, much if I don't have that number, because it is helpful to me. And sometimes I'll look back to a couple of different CBCs to see where they were at. But if it's there, I think it's worth addressing and noting.
I agree. I have started, especially my first visit with patients, looking at historical data and just making a mention to myself about if there's a history of elevated EOs in the past, just to plant that seed for myself in the future. If they're exacerbating, if they're not responding well to therapies, should I be looking at this patient like a type 2? We did a podcast a couple months ago with Dr. Jamie Rutland about biologics in COPD. And we kind of briefly touched on overlap, and we briefly touched on kind of discussing neutrophilic airways, eosinophilic airways being separate entities, COPD versus asthma. And he made a great point, which was an airway is an airway. Treat the airway, right? Treat the predominant disease, which is what Gold is saying. And, what you were making a comment with there. And, so I almost wonder, how much it's going to matter with, really trying to figure out, is it asthma? Is it COPD? Is it overlap? Just identifying an airway dysfunction and identifying the inflammatory factors behind it. So, we kind of talked briefly about, treatment, but is there anything out there in your research that you've been doing on this? Because I know you just gave a great talk on overlap syndrome, that you came across about treating these patients any differently. Does it matter?
Well, I mean, I do. I think it matters. And I agree. And by the way, that was a great podcast. And he had so much fun to listen to, not just educational, but just fun to hear. I want to be him when I grow up, when I'm 20 years younger. But yeah,
We all do.
but I do think it makes a difference. And an airway is an airway. And if you can kind of figure out, at least to some degree, hey, what's triggering this? What's likely to cause an exacerbation? Even questions like, if this patient has COPD and asthma, maybe macrolides, maybe they are more effective if they have both. If they have just asthma, I may not go to macrolide antibiotics early, but if they have asthma, maybe I'm going to go there quicker. And it does just kind of open the treatment window for different therapies. But it makes a difference. It makes a difference if you can control that eosinophilic inflammation better in some way. Maybe even somebody you'd consider, allergy immunotherapy or trigger avoidance with those patients. You know that eosinophils play a role. What can we do? What steps can we take to minimize that part? The neutrophilic part is still going to be our enemy, and exacerbations and preventing those, and vaccinations and being careful not to expose yourself. Those things that are so critical for COPD patients to keep them from exacerbating. But maybe I could kind of help with these other things. So it's worth noting. It may not change everything, but you can use it as motivation to make some other changes, or maybe to encourage somebody to quit smoking. Use those tools and recognize that when asthma is a part of it, COPD there, but now I'm adding asthma, or maybe they always had it. And I just kind of, that was a light bulb moment. Then I do want to recognize that I may have treatment options that I didn't have before.
So I want to go back a little further when we were kind of talking about phenotypes of patients and where it could be confusing where to use this term asthma COPD overlap. So, these are three different case scenarios, and you tell me which one you would call overlap and what you would call the other
Okay.
two. Okay. I'm going to
All
quiz
right.
you.
Let's do it.
So the first one would be a patient with a lifelong history of asthma, never smoker, no occupational risk factors, no other exposures that we'd be concerned about other than their history of asthma, and maybe not very well controlled over the years. And they're now in their 50s and their lung function shows obstruction. Would you call that asthma COPD overlap? Because we have a chronic
Yeah.
obstruction.
So generally, no, not that term. That using that term, obstructive asthma makes a lot of sense, and putting something like non-reversible asthma or those things, those all make sense. But really labeling that as right now as asthma COPD overlap would be not the correct term we would use most of the time for that particular patient. And yeah, and they still end up in the same kind of place with obstruction, and those patients, they've had a life of asthma that maybe hasn't been controlled. And at some point your lungs get frustrated and they start getting scarred. They don't respond. So there's damage, and it's largely irreversible in this particular patient. And so they kind of end up in a place that you might think of for the typical COPD or asthma COPD overlap patient. Their path to get there was very different, and kind of how you think about them is different. But yeah, in this case, not labeled, but treatment can be pretty similar for a lot of our patient groups.
And I think we're going to end up back at that term. And just your takeaway from listening to this podcast is treat the airway, treat the predominant symptoms, conditions, presentation of your patient. So, second case presentation for you would be a patient who has a 45 pack year smoking history, still actively smoking, healthy adult, was not symptomatic until they turned 72 this year, golfing. They're a little breathless when they're doing activities. You do their lung function, they have obstruction, they have some response to albuterol, maybe 12%, 200, a significant response according to Gina. Um, and they, again, have no previous other histories or triggers other than just when they're playing golf. Would you call that overlap in those patients?
I know that is a great question. And so I mean, I would go back and grill, I would this is going back to the interrogation, and I would, because I really want to know, hey, is there any history of, significant allergies? Was there any history maybe of asthma as a child? I in that case, with nothing else, they really don't meet those criteria, because most criteria, even the last GINA guidelines that have these two columns, and you kind of did the check boxes and then you added the check boxes, and whichever one won got that, that's how you treated them. And that again, we're not kind of doing that anymore. It's not count for phenotypes and then the one that wins gets the treatment. But and so this patient, I'm guessing, wouldn't have elevated eosinophils, no history of atrophy of any kind that we can see and think about. So now they're reversing, and that's great. And that may influence, just how much of a beta agonist you use, or kind of what you turn to first. And I would say make sure they can inhale, if not get them a nebulizer if they can't actually inhale strong enough. But that's the next podcast. But in those cases, I don't think that they really don't have an asthma component. They have reversible COPD. And so I wouldn't put them in that same category, because there really is nothing there to go on.
Well, not reversible, but
They have
hyper responsive.
they have a
Yeah,
responsiveness. And I do think it, by the way, it's very valid to really consider that. And, we give albuterol in whatever form to patients with COPD, despite the fact that bronchoconstriction isn't maybe their primary, symptom. But there's some resting tone. We all have resting tone in the airways. And so you can relax them a little more. But for this particular patient, they would probably do well if they were struggling a little bit and they had a nebulizer of albuterol or whatever. They would probably really feel better. So I would encourage them to turn to that first. Here's your inhaler. This is your rescue medicine. This is your cough medicine. This is your I can't hit this driver because I'm out of breath medicine, because we know that it does help you. So this might be benefit no matter where you are.
Correct. Tailoring it to the patient. Absolutely. All right. Last case study would be a patient who had childhood asthma. They had eczema. They can't be around cats. And, those symptoms have been pretty good. They may go through one albuterol inhaler a year for the last 5 years. And they also happen to smoke like a chimney. They've got a 35 pack year smoking history, and their pulmonary function test shows obstruction that's incompletely reversed. They may not even have a bronchodilator response on their lung function. Would you call that an overlap
Yeah,
patient?
thankfully I would. Look at one of them in the category. I would in that case. They meet the criteria for asthma, or they had, right? They had a previous diagnosis. Today, what now, this year they made it, maybe they didn't reverse for whatever reason, but they have a history of that, and that's met all the check boxes. They have the history of tobacco exposure, significant enough to do enough damage. And now we're seeing the fruits of those labor and that smoking history. And now we're seeing a patient that really does have the inflammation that eosinophilic and driving him in constriction, and enough tissue destruction, loss of elasticity, all those other things that this is impacting them. So I really do need that patient needs to be at the top of your list of getting them to quit smoking, but also just really treating all those things for COPD and exacerbations and preventing, and kind of continuing the thought of maybe we need to control your allergies. And for sure, that sounds like a patient that would likely be on a triple inhaler from the get go, where at the stage they were at that you just went over. So
Right, absolutely. And I think you brought up a really good point. They didn't reverse today. So that's one of the great reasons to repeat lung function. If you get a patient post exacerbation or having a bad day, they could look obstructive, and then you treat them, you repeat their lung function, and now they don't have an obstruction. And really, this is just a really bad
yeah,
asthmatic, right?
yeah, and yeah, we need to from now on only have PFTs done on not their best day and not their worst day. We need a medium day.
Yeah.
I don't want you great and I don't want you terrible. A medium day, and that's really true. And I will say, by the way, that's true for the eosinophils. I want to do a whole thing on this because looking back to one eosinophil level on a CBC is great. But if that's not, and if it's 450, okay, you probably don't have to look at a ton more. But if it's not there, look back. You maybe can't tell how much, had they been on prednisone or whatever, what was their life like at the time? Eosinophils react a little bit to even things like seasonal change to a degree, not a lot, but it does change. And so if you have the opportunity to look back 2 or 3 CVCs and see where they're at, that can be helpful too. And just deciding if this is playing a role and it's something you should address.
Absolutely. Well, Brian, is there anything else you would like listeners to take away about the confusing world of asthma COPD overlap?
Yeah, I encourage people to not shy away. It is not a syndrome in and of itself. It's two disease processes that can overlap. And if you've got a patient like this last one, asthma clearly has an atopic phenotype, but they have done something to their lungs, or it could be genetic. It could be alpha 1, right? So either genetic COPD or, environmental exposure. If they're moving along that line, that's when you say, okay, what do the COPD guidelines tell me for this patient? Looking at exacerbations, macrolides, that may be something I think of with this patient quicker than I would have otherwise. Maybe something like azithromycin makes sense for an exacerbation. I'm going to go down that. I'm going to make sure and think about pulmonary rehabilitation, just making sure we're doing everything we can to prevent that exacerbation because they won't bounce back. And then the COPD patient that also has, the other side is the COPD patient that also has asthma, and just looking at them in very much the same way. Most treatments are an option for these patients. Consider those things. And you can reach out. You can reach out to the organization where there's lots of people that, well, like me, that love to talk. And so we love to help with that. But these are patients that you can help. They are patients where you can make an impact. And that's fun. It's fun for us to know, hey, I can help you. And just because you have 2 conditions, that may not be the worst thing. Maybe we now have new treatment options that we hadn't thought about before. So let's take that. So don't shy away. Get the PFTs, and if you get stuck, get some help because it is a thing. It's just not a syndrome.
Right. And to quote Dr. Rutland again, an airway is an airway. Treat the airway, treat the predominant symptoms and how it's trying to tell you, speak to you to let you know what's wrong with it. Is it inflammatory? Does it need steroids, inhaled steroids? Does it need macrolides? Like you said, it's more that type 2 patient. Or, is it really just as, stingy old COPD obstructive airway that needs more of the, lama lava lama therapy? So, kind of definitely tailor it to the patient. Don't get too wrapped up in the nomenclature, but definitely make sure that you're paying attention there. Well, Brian, Thank you so much for joining us today. Appreciate you and you sharing all your information, all the research you've done over the summer that you were getting ready for your presentation. I think everyone is going to walk away hopefully understanding this a little bit better. All right. Don't forget, you can get CME credit for this podcast. The link to get your CME credit is in the show notes. You should be able to get them there. They're also on our website. If you can't find it in either of those places, email info@homeapp.com and we will send you that link. Brian, again, thank you. And don't forget to follow, like, share this podcast. It's the best way to support APAPP. Thank you.